Your slide is stagnant. It's not moving.
It moves. Now moving.
No, doctor.
Okay.
No, doctor. It's not moving. We can't able to see. Only this is stagnant screen. Yeah, now it's moving.
Okay. I will start. We say structurally normal heart, but if we do autopsy, we discover that there was problem in the heart. So this study did autopsy and found that the sudden death occurs in age younger than the old age. The causes of sudden cardiac death are Wolff-Parkinson-White syndrome, long QT syndrome, Brugada syndrome, early repolarization syndrome, short QT syndrome. All these we call it channelopathies. It is abnormal gene composition that is inherited. The combination of a triggering event and a susceptible myocardium has evolved as a biological model for the initiation of lethal arrhythmia. The electrophysiologic effects of cocaine have been examined in tissue preparations, animal models, and human subjects. The drug has class 1 type activity with significant effects on myocardial refractoriness. In addition, cocaine can have a pro-arrhythmic effect similar to that induced by quinidine as the result of triggered activity from early after depolarization associated with prolonged QT. Thus, cocaine ingestion could induce ventricular arrhythmia independent of its effect on the coronary arteries. So this is one of the causes of sudden cardiac death in apparently normal hearts. I know case was taking cocaine and died suddenly. This group of persons who died suddenly and they were subjected to post-mortem examination, they found coronary artery disease in 65%. Congenital condition 14%, myocarditis 10%, arrhythmogenic right ventricular dysplasia 4%, hypertrophic cardiomyopathy 4%, aortic stenosis 2%, coronary dissection 2%, unusual findings 2%, idiopathic dilated cardiomyopathy 1%, sarcoid 1%. So apparently we cannot see this, but post-mortem can reveal it. Now we will discuss each item. Early repolarization, there is elevation of the notch J point on the descending limb of the R wave, like this. And it has two types, associated with ST elevation with upward slope or associated with no ST elevation. This 43-year-old woman with paroxysmal atrial fibrillation episode of chest pain couple of years ago with slightly elevated troponin and normal coronaries on catheterization. Patient is a runner with no history of syncope. Brother has atrial fibrillation and had cardiac arrest in age 40 years and has ICD. What do you tell the patient? Straight to ICD or call me when you get sudden death? Again, the patient is having early repolarization. You see the J point is elevated and is having RSR- in V1. So early repolarization with elevated ST segment. This ST segment is elevated 1 millimeter. This with family history of sudden death, she must put ICD. This is the lesson from this case. Again, 23-year man, perfectly healthy, but his brother died in the shower suddenly. He is having elevated ST segment with J point elevation, early repolarization. So this definitely must get an ICD. Implantable cardioverter defibrillator. Again, we show here elevated J point without ST elevation, and here elevated J point with ST elevation. This is the more dangerous. This is benign, this is malignant. Again, the ST segment elevation, if it is ascending or horizontal, the more it is ascending, the more dangerous. Young male in excellent health, no problem, except in the ST is elevated here. This is J point elevation with ST elevation. You see here in B3 ST elevation. This is early repolarization. I finished about early repolarization. Now we come to another subject, Brugada syndrome. Rsr- in B1, incomplete right bundle branch block, and the raised ST with downward slope like this, classic. Brugada divided it into type 1, 2, 3, and then he said, no, it is wrong. It is type 1 is fully manifest, type 2 is not fully manifest, but there is no something called type 1 or type 2. I went to assess the Brugada possibility of this. If the R wave is fractionated, this is high risk. If there is early repolarization associated, this is high risk. If there is gene mutation, this is high risk. So we always ask in the exam of the cardiology, the student, what are the risk factors for sudden death in Brugada syndrome? When the R wave is fractionated like this, you see the R wave is fractionated and there is spontaneous type 1 spontaneous, this is high risk. Fractionated QRS, if the patient gets a syncope, if there is inducible VF, some references said inducible VF in the electrophysiology laboratory is premonitory or predictor of sudden death, but in this slide says that it is not predictor of sudden death. Again, this case is Brugada syndrome, Rsr- and there is ST with downward slope associated with early repolarization. So the patient is having the following: incomplete right bundle, ST elevation with downward slope, Brugada, fully manifest, and elevated J point. So 3 things. So this is, you must get ICD. Arrhythmia-free survival in patients with Brugada with and without early repolarization. If there is early repolarization, mortality is more than without. This patient is having ventricular premature beat R on T phenomena and induced torsade 1 and PF. So this is one of the causes of sudden death also. How can this happen in patients with catecholaminergic ventricular tachycardia, vulnerable myocardium? This is another strip of Holter. The patient got BF until complete arrest. Conventional risk factors for sudden cardiac death in patients with coronary disease: signal average ECG, electrophysiological study, frequent premature ventricular contractions. What is the meaning of frequent? If it is more than 10 per minute, if it is more than 200 per day, it is significant. Measures of QT dispersion, T-wave alternance, we can measure it manually or by computer. Measure autonomic heart rate variability by Holter monitor. Functional surrogates, coronary artery disease risk factors, ejection fraction. If it is low, it is premonitory to sudden cardiac death. If the ejection fraction is below 30%, you must put ICD. If there is severe hypertrophy, left ventricular hypertrophy, if there is dyspnea grade 4, is also a predictor of sudden death, and elevated beta natriuretic peptide. The gene is very important. Not everyone with risk factors will die. The one who is having risk factors. Congenital arrhythmogenic syndrome. Congenital arrhythmogenic syndromes, right ventricular dysplasia, hypertrophic cardiomyopathy, dilated cardiomyopathy, significant mitral prolapse, anomalous coronary artery. Anomalous coronary artery is a cause of sudden death. We saw cases. Congenital arrhythmogenic syndromes with minimal structural heart disease, long QT, Brugada syndrome, Wolff-Parkinson syndrome, idiopathic ventricular tachyarrhythmia, short QT, catecholaminergic ventricular tachycardia, congenital complete heart block. The underlying arrhythmia of sudden death in 62% VTAC, 17% bradycardia, 13% torsade 1, and 8% primary VF. This is example of incomplete right bundle branch block and S and epsilon wave on the QRS. This is pathognomonic of right ventricular dysplasia. and the diagnosis is by magnetic resonance. The patient developed ventricular tachycardia. The pattern is left bundle branch block, but with right axis. Whenever you see left bundle branch block VTAC with right axis, remember that it is coming from the right ventricular outflow tract, and the most probable etiology is right ventricular dysplasia. Another example of long QT syndrome with implantable cardioverter defibrillator. The patient got to SAD 1 and the pacemaker fired and returned sinus rhythm. Why the pacemaker fired after a long period? It is programmed to wait, maybe the arrhythmia subside by itself. Another example of long QT that developed ventricular tachycardia. Of course, in the exam, we ask the students, this is very clear, very evident, very long QT. This atrial fibrillation, very rapid. When you see atrial fibrillation very rapid, it is due to accessory pathway, Wolff-Parkinson syndrome. And if the RR interval is less than 250 milliseconds, he will develop ventricular fibrillation. So more than once, I see a patient with atrial fibrillation in Parkinson syndrome. I tell him immediately you must find money or agent or hospital to make ablation for you. You cannot wait like this. Catecholaminergic polymorphic ventricular tachycardia is an inherited arrhythmia syndrome, so-called channelopathy, is characterized by occurrence of adrenergic mediated polymorphic ventricular tachyarrhythmia. The prevalence of catecholaminergic polymorphic ventricular tachycardia in the general population is about 1 in 10,000, although rare recognition is important because it is of high mortality rate, up to 50% in severely affected untreated individuals up to age of 20. Many times we read in the newspaper, a young girl was swimming, died. A young girl was exposed to emotion, died suddenly. So the catecholaminergic ventricular tachycardia is one of the explanations. This is polymorphic ventricular rhythm, one above and one down. 12 lead ECG during stress test showing typical aspect of bidirectional ventricular tachycardia. Bidirectional, very horrible. It is a predictor of going to VF. Must be treated immediately by cardioversion, amiodarone, and then ablation. Another example of supraventricular tachycardia by Holter, ventricular tachycardia. Current management of catecholaminergic polymorphic ventricular tachycardia, beta blockers, implantable cardioverter defibrillator, flecainide, propafenone. Non-ischemic VTAC, high risk subgroups who need further evaluation. We have cases of cardiomyopathy, not ischemic. So the high risk if they are survivors of sudden death, recurrent unexplained syncope, idiopathic cardiomyopathy with syncope or VTAC, hypertrophic cardiomyopathy with syncope or VTAC, right ventricular dysplasia, long QT syndrome. All these are non-ischemic ventricular tachycardia at high risk. Again, another example of long QT that was exposed to got to ventricular tachycardia. The pacemaker did not fire, but gave overdrive suppression, hoping that it will recover. But instead of recovering, it went to VF. So he gave electric shock and returned sinus rhythm. Clinical syndromes treated with implantable cardioverter defibrillator. Cardiac arrest survivors, VTAC not hemodynamically well tolerated, idiopathic cardiomyopathy, syncope or VTAC, hypertrophic cardiomyopathy with syncope or VTAC, right ventricular dysplasia, long QT syndrome, Brugada syndrome with syncope, or positive electrophysiologic study showing PF. In conclusion, the vast majority of sudden cardiac death patients had structurally abnormal hearts, but in as many as 30% abnormality were non-specific. For patients with structurally normal hearts, the autopsy, clinical history, and combination can uncover potential mechanism of sudden death in 57% of cases. Apparently, we see no problem in the patient, but when you examine post-mortem or very strict examination by magnetic resonance and electrophysiologic study, you discover that there is hidden problem. Establishing structural normality is an essential prerequisite to making a diagnosis of this entity. However, focal manifestations of condition such as myocarditis, cardiomyopathies, small tumors may escape detection in survivors of sudden cardiac death. We confess that we can miss, I myself, professor of cardiology, can miss cases Furthermore, non-specific abnormalities such as interstitial fibrosis, mild myxomatous mitral valve are difficult to diagnose to make in the cardiac arrest survivor. The gold standard for confirming absence of or presence of structural abnormality is the pathological examination of by postmortem. Thank you. The lecture is put on YouTube. My channel, Samir Rafla, is put on Facebook. My channel, Dr. Samir Rafla Lectures. So you can find a copy of it. Just say to Google Samir Rafla sudden cardiac death. You will get a copy of the lecture. Thank you very much for giving me this opportunity. Thank you. Ready for any question.
Thank you, Dr. Samir. The floor is now open for any questions.
If anyone wanted to say, we may see patient with syncope and find no ECG abnormality or echo abnormality, and you say to him, go, you are free. And the next week we hear that he got sudden death, because the etiology sometimes is hidden. It needs provocation to show it. Do all the best of exams to check exercise ECG, Holter monitor, provocation by Ajmalin, electrophysiologic study to reach final multi-slice CT for the coronary. Must do everything to get the correct diagnosis. Okay, if there is no question, thank you very much.
Thank you, Dr. Samir. I would like to now call upon Dr. Syed Raza of Avali Hospital, Bahrain, to deliver his keynote talk on the title, Sleep Apnea as a Cardiovascular Risk, an Under-Recognized Medical Problem.
Thank you very much. May I ask